Hello and welcome. My name is Dr. Amer Johri from the Cardiovascular Imaging Network at Queen's University. Today, I'm joined by my trusty sonographer, Casey Salata. Casey, say hello.
Hi.
Casey is going to be showing us how to acquire images for the assessment of pulmonary hypertension. So today, we'll be looking at the size and area of the right ventricle and the right atrium. We'll also be assessing how to estimate pulmonary artery systolic pressure from the TR jet, as well as talking about the superiority index. All of these measures are from the new ASE 2025 guidelines for the right heart and assessment of pulmonary hypertension. So thanks for joining today. The purpose is to talk through some of the acquisition principles and some of the measurements. Not all labs are doing all of these measurements, but it's good to think about which ones you may want to incorporate in your lab, which ones you're already doing, and which ones you may want to practice a little bit more. Let's get started. Here we are getting started with the right side of the heart for our patient model here. And Casey is focusing on the RA to begin with. Looking at the right atrium is important because it helps us determine whether there are elevated right-sided filling pressures and also reflects upon RV diastolic dysfunction. The RA area is also strongly associated with morbidity and mortality in pulmonary hypertension. The RA area or volume can be indexed to body surface area and should be part of standard echo reporting. So Casey, tell me, do you feel like you're happy with this image? Tell us what you're doing.
I've gone lateral from my sort of true apical four-chamber. Gone lateral, and then I'm going to angle a little bit superior just to make sure I'm seeing the entire right atrium. And then, Mateo, can you breathe out for me? Hold your breath. Good, and breathe.
So tell me a little bit about what you're doing with your probe and how you're tilting, and what are some tips and tricks and pitfalls?
Yeah, so I have slid more lateral to get into more of an RP focused view, and then to see the right atrium well, I'm angling kind of superiorly, just like this. I think common pitfalls that you can sometimes feel that you can see the right atrium better from this type of axis where you're in your true four-chamber.
Mm-hmm.
But the new guidelines do want you to be more lateral than that.
Okay.
Just to make sure we're doing it in a standardized way.
Okay, great point. So can you show us how we would do the RA measurement?
Sure. Breathe out again for me, Mateo. Hold your breath. Good, breathe. So I'm just going to cycle back to end systole.
RA major dimension and minor dimension, if you can show us.
So which cycle I like better. And the tricuspid valve is just closed. So for our major dimension, we're going kind of in the center of the tricuspid annulus, just coming back like that. And good. That's our major dimension.
Great.
That's good. Use a Phillips. Our minor dimension will be from the free wall into the interatrial septum. Like that. It doesn't seem to show the actual lines on this one.
Okay.
Look at that afterwards.
All right.
I'm just kind of drawing a line like this.
Yeah.
And then a line like this as well.
Okay, great. And you're excluding the right atrial appendage if you see anything like that, and the IVC in case you see anything in that view.
Correct.
Great. All right. Thank you. Could you also show us how you do the RA trace?
So that will be from the same view.
And tell us where you're getting to in the cardiac cycle.
Yeah, so I'm going with end systole when the RA should be biggest, just right after just before the tricuspid valve is open. You just kind of trace along the edge. You want to be on the blood tissue interface.
Yes, I'm curious how you're going to trace this area here where we don't see the interface very well. A little bit of guesswork.
A little bit, yeah, I would do. I also don't usually trace on the machine. Probably something like that.
Okay. Great. So next we're going to move on to RV size. So remember, RV enlargement is a hallmark of chronic pressure overload and maladaptive remodeling in pulmonary hypertension. RV is really important for risk stratification, monitoring disease progression, and assessing response to therapy. So Casey, can you show us how you start off with your RV acquisition? We want to also look at RV thickness in addition to chamber size. So tell us how you get the RV focused apical 4-chamber view.
Sure. So the RV focused, if you start in your 4-chamber view, you're going to slide laterally, just like we did for the last one. Slide laterally, you want to see a nice like crescent-shaped RV.
So how do you know whether you're in the focused view as opposed to a regular 4-chamber view?
I'd like to see the crescent-shaped RV. You also, in a normal 4-chamber, your LV apex is underneath the center of the image.
Okay.
When you go more lateral, then you're going to have your LV apex sort of more this way.
Okay.
Just breathe out for me, Mateo. Hold your breath. And breathe. So then when I go to measure the RV size, again, I'm going to go, this will be end diastole. I usually go by valve timing. So as soon as the valve has closed,
can you show us that part again?
Yes. So, end diastole, the valve is closed, and then we're going to take a measurement that's from blood tissue interface with the lateral annulus, and then come into the septum.
Right. So this is the RV basal diameter. Yeah.
Yes.
And looks like you're measuring just beneath and parallel to the tricuspid annulus from the RV free wall to the interventricular septum.
Yes.
Can you show us the RV mid-ventricular diameter? I understand that's midway between the tricuspid annular plane and the apex, parallel to the tricuspid annular plane from the free wall to the interventricular septum.
So it would come up kind of like this. Ideally, I would maybe see this area just a little bit better for that measurement.
Okay.
But it'll be along the same plane as my last measurement.
Great. And can you show us the RV longitudinal dimension? I understand you're going to measure just beneath the tricuspid annulus from the midpoint to the tip of the RV apex.
Probably be something like that.
Okay. Okay, that sounds great. Okay, why don't we do the RV ones? So why don't you show us the RV basal diameter and just talk through it.
So for the RV basal diameter, I've gone my RV focused view, and I'm going to end diastole right after the tricuspid valve closes. And I'm going to place a caliper just in the RV3 wall, just by the lateral annulus. So I kind of follow the same angle as the annulus of the tricuspid valve, right over to the septum, like that.
Mm-hmm. Great. And now the mid-ventricular diameter.
So the mid, I'm just going to come again against the RV3 wall, following the exact same angle.
Mm-hmm.
Kind of midway between the annulus and the apex.
Okay. And then the longitudinal diameter.
So the longitudinal diameter, you want to are the apex. The most clear, but I think it's right in around here.
Mm-hmm.
And then you want to go just kind of midway to the annulus of the tricuspid valve.
Okay. Okay, so you don't normally do RV end systolic area and end diastolic area, is that correct? Or do you do that with every echo?
Correct. No, we aren't currently doing that in our lab.
Okay.
That's something we begin to work on.
Okay. Should we try doing that here?
Sure. So again, I would go to end diastole.
So this is the RV end diastolic area.
Exactly.
And this is a very typical image that you may acquire of the right ventricle. As you can see that sometimes the walls are not well seen. This is probably a more typical example than what the lines, which is a very well visualized right ventricle, which is not really everyday practice. So thanks for showing us this in a more challenging patient.
So then I'm going to come in and systole just before the valve opens. So I'm going to do the same thing. Don't normally trace on the machine. Trying to not include any of the moderator band.
Okay, so that's great to see you've left out some of the moderator band there and some of the trabeculations as well.
In our lab, we often do our measurements offline on the computer, and then the echocardiographers can adjust the measurements.
Right.
They see fit
You have more
as
control
well.
of the cursor that way, right?
Mm-hmm. Yeah. But it looks like this package gives us a fractional area change as well.
Okay, great. So you may have a fractional area change measurement in your package. So some normal measures to remember are that the RV basal diameter is normally less than 4.1 centimeters. The longitudinal parameter is less than 8.2 centimeters. And the mid-ventricular diameter is less than 3.5 centimeters. Why don't you show us how you measure TAPSE from this view?
So I think the guideline is now suggesting that you could zoom in on tricuspid valve annulus just to get a better measurement. But you want to place your M mode cursor right in the tricuspid valve annulus of the lateral wall. And this sweep speed is the optimal for a measurement, I would say.
What's the sweep speed you're trying to achieve?
Well, I just want to be able to see it really well and have it take up a good portion of the screen.
Okay.
the Philips, its speed is currently set to fast. This being it's 100 millimeters this will go.
Okay.
So it's a measurement in the vertical plane. And ideally, I'm just kind of lining up with this curve here.
Okay.
So down just a little bit.
Now, I've seen people measure straight up, and they also measure at an angle as well.
Yeah. I don't think it matters because it's going to take it from, it's going to take the vertical. This Philips machine only allows me to go up and down.
Okay.
So I'm not able to come over. But if you were to measure right along the line, which I like to do actually,
yeah,
it doesn't really make a difference going to the side because it's only taking the vertical.
The height.
Component.
Okay.
Yes.
Got it. Yeah. All right. So normal TAPSE is greater than 17 millimeters. So why don't we move on to how to obtain some additional measurements, including the sphericity index. So should we do that next, or would you normally do the pulmonary artery systolic pressure here, since you have probably, a good look at the tricuspid valve?
Yeah, so we do it offline so I can choose where I had the best TR assessment from.
Mm-hmm.
It usually is from the apicals, although I would go into a more modified view.
Okay. So why don't you show us that?
Medial like this.
Okay.
It's usually a better angle.
Okay. And when you say better angle, what do you mean by that?
I'd like to be very parallel to the TR jet to get the highest velocity that I can.
Okay.
So I've just slid medial, so now I'm kind of coming like this.
Okay.
With my ultrasound. My color on, you can see that there's just a tiny bit of tricuspid regurgitation there.
Right.
And then you want to line up with your cursor nice and parallel to that flow. Use continuous wave. And as you can see, Mateo doesn't have a lot of tricuspid regurgitation. We don't have a full spectral envelope here, so I wouldn't measure this. If he did have a full envelope, you want to measure just right at the tip of it. If you can imagine, it might be something like this.
Right.
But I wouldn't use this to measure his pulmonary.
Okay. Are there things we can do to enhance the tricuspid regurgitant envelope if we needed to?
You could consider doing a bubble study.
Mm-hmm.
Agitated saline can kind of enhance the signal a little bit.
Right.
If you were giving an ultrasound enhancement agent, you could throw a cursor through with that as well.
Okay. And in this case, we're not really seeing findings consistent of pulmonary hypertension, so you may not proceed to do that.
Correct. So I wouldn't do that measurement in this instance.
Okay.
But of course, you're looking for the tricuspid regurgitation everywhere you can in every window, trying to get a nice jet.
Okay. Can you, why don't we talk a little bit about the eccentricity index next? So the guidelines are suggesting measuring that in the short axis view.
They're still leaning forward just a little bit here.
So tell us about how you're optimizing this view.
Well, I'm trying to have a nice round-looking LV short axis here. Because looking at the septum will tell you a lot about what different pressures are between the RV and the LV.
Mm-hmm.
His septum is nice and round in systole and diastole.
Right. So the guidelines mention the sphericity index and the eccentricity index, which are two different things, but similar principles. With the eccentricity index, we're measuring the major and minor diameter of the right ventricle. Something like that, and then perpendicular to that as well. And we do similar measurements for the sphericity index in the RV-focused apical four-chamber view as well. All right, so why don't we move on next to your IVC measurement? So if you can show us that.
Now you can put your arm down. So I'm going to have you bend your knees and just put your feet both on the bed for me there. Just a little bit. So I take this from the subxiphoid subcostal area. It does help to have a patient bend their knees just so that the stomach muscles are a little bit more relaxed. So this is the IVC here.
Okay.
They want the IVC diameter measurement, and expiration. So Mateo, can you breathe out for me? Hold your breath and breathe. So you measure that usually at end diastole. And you're going to be just beside the hepatic vein.
Okay.
And kind of along the direction that the IVC is going.
Okay.
Perpendicular to it.
Okay.
So something like that. And then we're also wanting to make sure that the IVC is collapsing well. And you just take a big sniff through your nose for me, Mateo. Good. And breathe normally. And you can appreciate that collapsed really well.
And how much collapse are you looking for?
You're looking for more than 50% collapse. And his IVC was not dilated, and it collapses greater than 50%. Fully, so we give him a right atrial pressure of 3.
Okay, great. And would you do this in M mode or 2D?
I believe the guidelines and best practice is to do it in 2D.
Okay.
Our lab, currently our package is set up to do the measurement using M mode.
Mm-hmm.
I think maybe moving forward 2D might be better, but you can do it using M mode as well. You just want to make sure your cursor is really nice and well aligned. Adjust my angle a little bit. So I would do it from here then.
Okay.
Take a big breath in for me, Mateo. Big sniff through your nose. Good. And then just breathe normally.
That really shows it nicely.
Yeah, so you can also use M mode to appreciate that as well.
Okay, great.
And then you can just measure it right here.
Okay. And I think the last thing, if you can show us today, is how you interrogate the pulmonary valve for pulmonary regurgitation, which may also occur in patients with pulmonary hypertension.
Sure. I'm going to get you to turn back in your left and put your left arm up again. So you can see your pulmonary from the long axis of the guidelines have us measuring it from the short axis. You breathe out for into. Hold your breath. And breathe. I just tried to bring in the outer wall. Let me try that one more time. Breathe out again for me, Mateo. Hold your breath. And breathe. Breathe out again. Hold your breath. And breathe. So I've come a little bit more medial actually, and I've angled a little bit superiorly. I'm just trying to really visualize the pulmonic valve and the pulmonary artery nicely. See those branch views coming into. I can fit you lean forward even more. That's brilliant. Okay, so here I've got a more optimized view of the pulmonary artery. So you want to go to end diastole, and then you're measuring the diameter kind of midway between the pulmonic valve and the bifurcation of the PAs.
Okay. Good.
Sorry, well, let me measure them 20. And up. So kind of midway. Again, you want to be at the blood tissue interface.
Okay.
Like that.
And can you show us how you acquire the pulmonary regurgitant jet?
So you do want to optimize your color flow. Frame rate's not bad here, but you can also narrow your sector width just to get a higher frame rate. I'm just looking at the color flow, and I want to see a little bit of regurgitant jet through the pulmonic valve. Again, we don't happen to have too much right now. And then again, you want your cursor to be very parallel to flow, and I'm just trying to line it up with that width of the eye that I see. Just kind of optimizing my scale a bit so I don't think that I'm looking at.
Not much PR there. Yeah.
Not much. You can kind of see the end diastole there.
Okay. Great.
And then you can just place kind of a cursor right on that.
Great. Okay. Well, that brings us to the end of today's session. As you can see, Casey was able to acquire images of the right ventricle and the right atrium. Today's example was a typical patient in which imaging of the right ventricle can be challenging. Nevertheless, implementing the new right heart and pulmonary hypertension guidelines is important. There are a few basic measurements and image acquisition protocol parameters that should be acquired in everyday patients, which we acquired today. Today's patient did not have significant pulmonary hypertension, but we still looked for things such as the tricuspid regurgitant jet to assess pulmonary artery systolic pressure. We still employed the eccentricity index, and we also looked at TAPSE as well as chamber dimensions. Certainly, we may have more advanced parameters that we can explore next time when we image a patient with pulmonary hypertension. Thank you for joining us today.